Good evening, everyone. Welcome to First Aid AMC MCQ. Today, we are going to start our free 2-week session. And most of you know about our First Aid AMC MCQ course, I guess. And you know that the course has everything that you need to know for passing this exam. We designed this course in a way so that it can be utilized for everyone in each stage. Like many of you might be just a beginner, you don't have any idea about AMC. Many of you can be in the middle of your preparation, and many can be just at the end of your preparation. So whether you are a beginner, in the middle, or at the finishing of your preparation, the course is designed in a way so that you can utilize this in every possible ways. So you know that we provide the previous class recordings. So if there is someone who has already got their exam date, like let's say your exam in 2 months' time, you can still join the course given that we have every recordings of our just finished course in your portal. So once you make the payment, you will be getting the access of the whole course. So you can utilize the materials in your own time. Many can have a lot of time, like you might not be doing any job at the moment, so you will have more time to prepare. So you can utilize those videos and finish the course in your own time. And also you will be joining the new classes as we do. Okay, so we have our first class few weeks ago, and we did a trial class where we discussed about some psychiatric topics. I hope you enjoyed it. The recording of that class is given in First Aid AMC MCQ group. So if you missed it, I would definitely advise to just listen that class, because we discussed how AMC works, like just a basic of AMC MCQ exam. We have a discussion about it already. So tonight we are not going to do any kind of discussion regarding the exam format and all. We are going to do some discussion about question solvation. Part of your preparation will be solely on solving questions, especially past papers. So a lot of questions you will be getting where you'll solve those questions with your study partner. We will be doing that in our course. So a huge amount of your preparation will be just to solve questions. And also 50% of your preparation will be dependent on theory. So that's why our course is blended in a way so that you get the theory knowledge and discussion with us, and you utilize those theory knowledge to solve the question. But tonight, question solve will be from anywhere. There is no syllabus for it. So it will be kind of an exam-like questions that we are going to do today, so that you have an idea how questions can appear in your exam and how to come to a diagnosis and how to come to the right option. What are the tips and tricks? What are the trap? Like a lot of time there will be something very obvious in front of your eye in the question, and you would think that, well, this is the answer, but definitely you just fall into a trap of the examiner. So we will show you what are the traps that you should never forget about. What are the main point that you should focus when you are reading a question. So our tonight's session is mainly based on that. It can be a bit difficult for beginners, given you might not have a lot of information that you need to solve these questions. But don't worry, once you start the course, once you start the preparation, things will get easier and easier every day. Okay. Let's start. So we'll be doing question solvation, not any theory class. We divide theory and the question solve in a different way. In theory class, we focus on theory mainly. We don't focus on the questions. In question solve classes, we focus on questions only, and we just touch the theory just a bit. Just the important ones, not the whole theory that we discussed in these classes. Okay, so throughout this 2-week session, you will be getting a lot of question solve class. In those question solve classes, don't assume that we are going to discuss theory in that classes. Theory is totally different, which will be done mostly by me, and I will be doing every theory that can ever come in your exam. Okay, so don't worry on that part. First question. You have got a patient who is diabetic. Now see that where I am using my main points. So the points that I am looking into when I'm solving a question, that's what I want you guys to understand as well. So it's a diabetic patient and having an ulcer on his right foot. There was a picture given where the ulcer was at the medial malleolus and there was one ulcer at foot with skin necrosis and inflammation. Patient is a diabetic, so is it well-controlled diabetic? So HbA1c is 6.5. Normally, if it is HbA1c is less than 7.5, then the diabetes is well-controlled. So between 6.5 to 7.5, it is well-controlled diabetes. So this patient having a well-controlled diabetes, he was admitted and antibiotic was given. You have taken swab and you have sent it for culture and sensitivity. What will you do after that? Do you want to go for an X-ray, MRI, bone scan, Doppler scan, or just a complete blood count? Now, before even we discuss this question, you need to understand the pattern of question. In some questions, they will ask you, what will you do next? Or they can ask you, what is your initial choice of investigation? Or they can ask, what is your next most appropriate management or investigation? Or they can ask, what is the next best step of management? So these are the pattern of question. Any question where there is next, it means what is your initial investigation, not your best investigation. That's important to know. Same in here, what will you do after that? Which means they're asking the step-by-step approach. You have given antibiotic, you have taken swab, what you want to do next. Okay, so that's next. So anything which has next, initial, next best, next most appropriate, next appropriate, everything is initial or next test. Some questions they will not use next. They will ask you, what is your best investigation of choice? What is your most appropriate investigation for this patient? Or what is your most appropriate management for that patient? Remember, investigation is a part of your management as well. Just because they write management, don't think that they are not asking about investigation. So management is also included in investigation. So if they're asking management and before you can manage a patient, you need to investigate that patient, you will investigate. Okay? So this is the first thing that you should understand, the question. Because if you know everything about a particular topic, but you don't understand what they're asking, then definitely you will not come to the right answer. So what do you want to do in a diabetic patient who has ulcer on the foot with necrosis? Which means that when a diabetic ulcer is causing necrosis, it means it's non-healing ulcer. And most of the time in the question, they will give you that it's been few weeks patient having this ulcer and it's not going anywhere. Okay, so it's not getting healed. So any patient who is diabetic and having a possible non-healing ulcer, what is the most important thing that you should not forget? What you normally want to rule out in that patient? Osteomyelitis, right? Very good. Yes, osteomyelitis is our main concern in a non-healing diabetic foot ulcer. Okay. Now, I will come to these questions just in a bit. Let's discuss this topic. So this is diabetic foot ulcer, common in foot and also the pressure areas. And sometimes it can look clean like this. Sometimes it can look very very inflamed or infected. So if there is oozing or discharge coming out, surrounding redness is there, then there is an infected or inflamed ulcer. But this one you can see that it's not that bad and eventually it got healed. So there are stages of diabetic foot infection. We divide this stage into mild, moderate, and severe. Mild means local infection involving only the skin or subcutaneous tissue, which means it doesn't involve the deeper tissue and there is no sign and symptom of any systemic inflammatory response. That means patient doesn't have any fever, nausea, vomiting, tachycardia. It's just superficial infection. And around the wound, the surrounding erythema is less than 2 centimeter. Like if you see this one, what is the surrounding erythema? So surrounding erythema less than 2 centimeter, that's also, it's a mild infection. How about moderate? There is local infection, so it's still not deep infection, but the surrounding redness is more than 2 centimeter around the wound. And sometimes it can be also a deeper one, like it's going deeper into the skin and subcutaneous tissue, causing abscess, osteomyelitis, septic arthritis. But it's still no sign of systemic inflammatory response. That means it's still no fever, nausea, vomiting, or tachycardia. So moderate means either it's going a bit deeper or the local erythema around the wound is more than 2 centimeter and there is no systemic sign. And severe means there is, or definitely it's going deeper and there is sign of systemic inflammatory response. Okay, so this is how we can know that is it a mild, moderate, or severe diabetic infection. So this is the main tips for your exam. And if you get a patient who has got diabetic foot ulcer and it's a non-healing ulcer for more than 2 weeks, you will be concerned of osteomyelitis. So for that patient, your next investigation should be X-ray foot. And if they're asking what is the most appropriate or best investigation for osteomyelitis, that will be MRI or bone scan. Okay? Sometimes they can give you a diabetic foot patient, but they say that there is yellowish discharge coming from the wound. That means it's the infected wound. For infected wound, before even you do the X-ray and anything, you need to take a swab from the wound, and then you will clean the wound, start the patient with antibiotic, and then you can do X-ray or MRI if you think that this is osteomyelitis. Okay? So that's important. That's if the question or if the picture that will be given to you in the exam, if in the picture you see that there is yellowish discharge coming out of the wound, then your first investigation should be wound swab. Send the swab for microscopic culture, clean the wound, and then start the patient with antibiotic. So what kind of antibiotic? The antibiotic of choice is for mild infection, we give anything, amoxiclav, cefalexin, flucloxacillin, or clindamycin. Moderate infection, you can give IV augmentin, cefazolin, plus metronidazole. That means you will add metronidazole with augmentin most of the time. And if it is a severe infection, then you will also make sure that you are giving some antibiotic which can kill gram-negative bacteria. So piperacillin tazobactam, you can give sulbactam, clavulanic acid, or even ciprofloxacin. So this is our choice of antibiotics. Sometimes they ask this question in the exam. So that's why you need to know that if this infection is mild, moderate, or severe, and based on that, you can treat them accordingly. Okay? Now coming back, this question, definitely it's not the full question, and we don't know the duration of symptom in here, but we know that this patient has got necrosis. If it is a necrosis, we are concerned because necrosis means it can go deeper structure. So if in that case, our first thing that we want to make sure that it is not osteomyelitis. So our next investigation should be X-ray. Most of the time, X-ray is unable to identify osteomyelitis. And if you are still suspicious of osteomyelitis, even after X-ray, then you go for MRI or bone scan. Okay, clear everyone? Now, why not Doppler? What are we going to get from Doppler? That's the question. We know that this is a diabetic ulcer, right? So our main concern if this patient has developed a osteomyelitis. With Doppler, you can find out if there is a venous insufficiency in this patient or if there is a peripheral vascular disease in this patient. Now, definitely you can do it, but what is your priority? Your priority is to make sure that it is not osteomyelitis. And in exam, priority is the first thing that you would think of. That means what's my first thing that I don't want to miss in this patient? Not something which can be done a bit later. Okay? Yes, Doppler might help to know that if this patient has got a peripheral vascular disease, but is it my first priority? No. My first priority is that this patient is not having an osteomyelitis. Once I can rule that out, I can do a Doppler to find out if this is because of peripheral vascular disease, then I can treat that patient if needed. Okay? So priority is important to understand in exam. You can only choose one option, and your one option should be the most important one. This is one of the guidelines that if we think a patient has got diabetic foot ulcer, how we start, how we usually proceed. So your initial investigation should be X-ray. And in the X-ray, if there is radiographic changes compatible with osteomyelitis, like let's say there is bone started, in the X-ray you can see that. If that is yes, then consider bone biopsy and then treat as osteomyelitis. But in the X-ray, you can't find out osteomyelitis. So then what you can do is that you look at the ulcer and you see that if you can see the bone, if you see the bone in naked eye, that means that it is a very deep wound and likely chance of osteomyelitis is very high. If you can't see the bone, then you can even use a probe, and with the probe you can see that if that probe is touching the bone. So if any of this is positive, then you will think that, well, there is a likelihood that it could be osteomyelitis. And then again, you can consider a bone biopsy, but before you consider bone biopsy, I would definitely do a MRI or a bone scan first. Okay, so a step-by-step approach is first X-ray, then MRI or bone scan, then a bone biopsy, then treat at osteomyelitis. All right, so that's your first question, and you can understand that how theory knowledge helps to solve a question. That's my main point for this question. Now let's move on. A young man came to the emergency department with big abscess under the arm. After draining the abscess, what is the next, or what is the investigation of choice? So what will you do after draining an abscess? So you want to start antibiotic, full blood count, you want to send the wound culture, you want to do a ultrasound or CT of the arm. Very good. So most of you are right. So definitely we need to do a wound culture, because if you start the antibiotic before the culture, then you might not even know what was this organism causing the abscess. So very important to understand, if you get an abscess and you have drained the abscess, your next step should always be take the swab, send it to the lab for microscopic culture and sensitivity, and then you can start an empirical antibiotic. Very good. Moving on to fluid balance chart. Now this is a very confusing topic. A lot of you always ask me multiple times that like how to do this fluid fluid balance. Excuse me. So let's discuss this. A previously fit 55-year-old man has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. 2 days after the operation, you note the following on his fluid balance sheet. You can see the input is 2 liter. And what is the output? Patient has got a nasogastric aspiration 2 liter, drain loss 700 ml, urine output 500. The biochemistry shows sodium normal, potassium is bit low, chloride okay, bicarbonate normal. Which of the fluid balance regimens would you order for the next 24-hour period? So it is a post-op day 2 patient who has got a hemicolectomy for a perforated cecal carcinoma. And they are asking about fluid balance chart for this patient, right? Now, before doing this kind of question, you need to first find out what is the input, that means how much fluid you have given and how much output this patient is having. So first find this out. So input, we can see that IV fluid is 2 liters, so that's the input. What is the output? So patient has got nasogastric aspiration 2 liter, drain loss 700 ml, urine output 500 ml. Now, any patient, there is some insensible loss from sweating, loss from skin, okay? That insensible loss that you can't see or you can't measure, we always keep it as 500 ml. So what is in here? So if you make it total, so you have got 2 liters, 700, 500 and 500. So 3700 ml. For your understanding, make it whole. So it's 3.7 liters, so make it 4 liter. Okay. So now you can see input 2 liter, output 4 liter. So how much deficit this patient having, guys? So how much fluid deficit this patient is having now? So you are giving 2 liter fluid, but patient is having 4 liter output. So 2 liter deficit is there. Okay, so keep this in your mind. Any patient who needs post-operative fluid balance, for everyone as a maintenance fluid, we follow this formula. 1 liter normal saline, 2 liter dextrose, plus 20 milli equivalent of potassium per liter of fluid. So that's usually for every post-operative patient. This is the maintenance fluid formula. Now, that doesn't include any deficit amount. So the deficit 2 liter that this patient had, you have to add it in this maintenance fluid. And how we usually add it? We add it to the normal saline. So you add another 2 liter normal saline with this existing maintenance fluid. So how much it will become? 3 liter normal saline, 2 liter dextrose, and then how much it will be? Potassium. How much? They say 20 milli equivalent potassium per liter of fluid. So how much fluid we are giving to this patient? 3 plus 2, 5. So if for one liter you are giving 20 potassium, 20 milli equivalent potassium, for 5 liter how much will you give? 5 into 20, which means 100. So 100 milli equivalent potassium. So this is your fluid balance for this patient for the next 24 hours. Okay, clear everyone? So if you see over here, you have got an option: 3 liter normal saline, 2 liter dextrose plus 100 milli equivalent potassium chloride. Okay, so any kind of fluid balance chart after surgery, this is what we normally follow. There is a lot of like ins and outs in this discussion, but this is the standard formula that usually you should follow for AMC. Is it clear for everyone? Any difficulty with understanding? How we are giving 5 liters? So you are giving 3 liter normal saline and 2 liter dextrose, so 5 liter. Okay, I have to repeat it. I know that it's not you guys. In every trial class I have taken so far, I had to always repeat this question. So it's fine. I'm happy to repeat this. It is a bit difficult, I know. So first of all, you find out the input. So input is 2 liter from here, and output 2 liter nasogastric aspiration, 700 ml drain, urine output 500, and another extra 500 for any insensible losses. So it becomes 3.7 liter. I just made it a whole number, which is 4 liter. So 2 liter input, 4 liter output. So patient having a deficit of 2 liter. Okay. Once you know that, then you will use this formula for every patient after post-operative. You use maintenance fluid as 1 liter normal saline, 2 liter dextrose, plus 20 milli equivalent potassium per liter of fluid. Now that's for everyone, but this patient has got another deficit of 2 liter, so you have to add this 2 liter with this existing fluid maintenance. So we add this 2 liter with the normal saline. So previously patient used to get 1 liter, now we have added 2 liter, so it becomes 3 liter normal saline. So 3 liter normal saline, 2 liter dextrose. Now for this one, 20 milli equivalent potassium for every liter of fluid you are giving. So you are giving 5 liter to this patient. So 5 into 20 equal to 100. So 100 milli equivalent of potassium. Okay. Clear for everyone? Good. Good, Dr. Prakash, Dr. Sumaya. Very good. You can use this formula for most of the post-op patient, but as I said, there is a lot of ins and outs. But that's more or less you can use. Moving on, patient comes back with Thailand with history of having sex with multiple prostitutes. After 1 week, patient presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat, atypical lymphocytes present, monospot negative. What is the diagnosis? Very tricky question, but if you know this virus, how they usually present, then you will not get into the trap. So this is one of the questions where you will see a trap, and if you don't know the topic, you will fall into that trap. So many of you are with Epstein-Barr virus and some of you are with HIV. And that's at least very good that you are with the most two important choice, because that's where most of the candidate gets wrong or most of the candidate gets confused. So it means you are in the right track. So let's discuss about this a bit. So you have got a patient coming back from Thailand with history of having sex with multiple prostitutes. So there is definitely a risk of HIV, hepatitis B, C, all the STI. After 1 week, patient presents with lymphadenopathy. So that's one symptom. Mild pharyngeal erythema, splenomegaly, and sore throat. You have got atypical lymphocyte and monospot test negative. Let's discuss how to differentiate Epstein-Barr virus from HIV infection. This is from your John Murtagh. And in John Murtagh, you will get this in various viral infection chapter. So Epstein-Barr virus is a viral infection. It comes similar like any kind of flu-like illness, but the main presentation is sore throat. So patient with Epstein-Barr virus can come to you with a fever. HIV can also come to you with fever. Fatigue, malaise is common in both. Tonsillar hypertrophy. Now, sore throat and tonsillar hypertrophy is not very common in HIV. It's very common in Epstein-Barr virus. So sore throat, tonsillar hypertrophy, exudates on the tonsil. If you get that, mostly we will think of EVV. But oral ulcer is common in HIV. Rash is common in HIV. Jaundice common in, not very common, but you can get it in EVV. Cervical lymphadenopathy can be found in both. Splenomegaly, about 50% cases you will get it in EVV and HIV rarely. Atypical lymphocyte, 80 to 90% cases in EVV, 50% cases in HIV. So you can see that how it can get confused in the exam because many symptoms actually match with HIV, right? But the way to differentiate HIV from EVV is EVV will have sore throat, exudative tonsillitis or pharyngitis. They will have splenomegaly and they will also have atypical lymphocyte. HIV, they will not have sore throat or splenomegaly. That's very rare. Now, if we go back, you can see that this patient has got lymphadenopathy, can be found in both HIV and EVV. Pharyngeal erythema, sore throat, this is common in EVV. Splenomegaly, common in EVV. So most of the symptoms goes with Epstein-Barr virus rather than HIV. Atypical lymphocyte can be found in both. But monospot test is negative. Monospot test is usually found positive in Epstein-Barr virus infection, but it's not specific or pathognomic, which means that there are percentage like in 20-30% cases, you can get a negative monospot test even in Epstein-Barr virus patient. So just because patient's monospot is negative does not mean that your EVV is out. So EVV still can be there if all the symptoms goes with EVV. So this patient definitely, the symptoms are going with Epstein-Barr virus rather than HIV. Okay, so it can happen in Epstein-Barr virus, and that is the trap. Many candidate, when they see this line, they just immediately think, no, it's not EVV because monospot is negative. But yes, 20 to 30% cases, EVV can have a negative monospot test. Okay. Here, everyone, and definitely it's not hepatitis because this patient hasn't got any jaundice. Ross River fever, it's a condition common in Queensland and it comes from mosquito bite. Patient usually presents after they goes for, like, sometimes they will give you a history that they went for hiking or camping in far Queensland or far north Queensland, and then most likely they got bitten by insect mosquitoes, and after a few days or weeks they will come to you with extreme tiredness, maculopapular rash in the whole body, and they can also develop kind of arthralgia, like they can have joint pain, muscle aches, and lymphadenopathy. That's Ross River fever, which is not going with this question. Why not CMV? Again, in CMV is very uncommon. CMV is common in patients who are immunocompromised in Australia. Someone who is taking anti-cancer medication, chemotherapy, or organ transplant patient, they usually get CMV. Not very commonly anyone else will get it. As you can see that for CMV, also sore throat pharyngitis is uncommon. Cervical lymphadenopathy, uncommon. Okay. Atypical lymphocyte splenomegaly can be there, but sore throat, tonsillar hypertrophy, this is not common in CMV. Okay. That's the thing, like travel history is a trap. Just because someone has got sexual history with multiple prostitutes doesn't necessarily mean that that patient has got HIV. What if the patient had sex with condom, right? So these are the things that's important for the exam. AMC tries their best to make you confused in every possible way in the exam. So the trap is important to understand. Something which looks like very clear cut in your eye, that is most of the time is not the answer in the exam. Because most of the candidate who will not know about EVV, whenever they will see this first line, they will not even think of anything. They will just choose HIV. That's where you get it wrong. Okay. Next question. A man coming back after a short trip from endemic area for only 5 days with severe jaundice. Fever. On examination, you found tender hepatomegaly, right? Because liver is tender and enlarged, so tender hepatomegaly. Investigation shows very high ALT, AST, GGT, and ALP. What is your most likely diagnosis? Acute viral hepatitis A, viral hepatitis B, malaria, infectious mononucleosis, or choledocholithiasis. So if you have got a patient who has this kind of travel history, and you have found a patient to have severe jaundice, fever, tender hepatomegaly, and very high ALT/AST. That's all that you need to diagnose hepatitis. Right? Now, why don't we think of hepatitis B? Why we think of hepatitis A? Because they said endemic area. There are very small, like when they talk about endemic area, they usually mean hepatitis A because it usually comes with a fecal-oral transmission. Hepatitis B endemic is not very common. So when there is a travel history or history of endemic area travel, then you would definitely think of hepatitis A or hepatitis E. Okay? And hepatitis patient will come to you with fever, jaundice, tender hepatomegaly, and you will also get high ALT and AST in that patient. Clear? Why not it is malaria? Because patient went to an endemic area. It could be malaria also. Why not it is malaria? The number one cause is that malaria, acute malaria doesn't give jaundice quite easily. Chronic malaria usually comes with jaundice and hepatosplenomegaly. And yes, that's also right. ALT, AST, these liver enzymes are rarely will be elevated in an acute malaria patient. You can get jaundice in malaria. That's not right. You can get it, but jaundice is not the commonest sign. And if you get jaundice in malaria, you will get it in a chronic malaria patient, not acute malaria. So these are the causes of tender hepatomegaly: viral hepatitis, congestive cardiac failure, liver abscess. And we discussed in here how to, like, what are the important liver function tests that we look for. Like if you think a patient who has got viral hepatitis, most of the time you will get ALT very increased, like sometimes it can be more than 5 times of normal value. If it is hemolytic jaundice, you get unconjugated hyperbilirubinemia. In hepatocellular jaundice, like viral hepatitis, both conjugated and unconjugated bilirubin can be increased. If it is an obstructive jaundice, most of the time, alkaline phosphatase will be elevated. If it is an alcoholic liver disease, then GGT and AST will be elevated. So these are the important things that you should remember, because these are the clues that will be given in the exam. Okay? And definitely we will have a theory class on jaundice. We will discuss this in detail. Moving on. You have got a patient who has got parotid gland swelling. CT shows superficial lobe involvement only, no facial nerve palsy. What is the most appropriate next step? FNAC, ultrasound, total parotidectomy, or superficial parotidectomy. So let's say this is a 45-year-old patient coming to you with a parotid gland swelling. CT shows superficial lobe involvement, no facial nerve palsy. What will you do next? Do you want to do a FNAC? You want to do ultrasound? What is the point of doing ultrasound when you already did a CT? That's the thing, right? So CT has everything that you need. So no need of doing an ultrasound when you have already done a CT scan. Do you want to just remove the parotid gland immediately? No, you want to know that what's this parotid gland swelling. Is it a benign tumor? Is it a cancer? You want to know. How you can know? By doing a FNAC. Okay. Now we will discuss a little bit about approach to the neck lump in adults. Now this is how you will know. Whenever you are confused that, well, I'm not sure about a particular topic, RACGP is your first thing that you would like to go through. So John Murtagh is your first book or any kind of guideline. Then if you want to know a little bit about the theory, Kaplan step to CK is also important. But if you want to see an Australian guideline about a particular topic, especially related to medicine, RACGP guideline will be your main guideline. Okay, even sometimes we take help from RACGP more than John Murtagh. So how to search these things? So I will show you all of this so that you know. Just 1 second. So let's say that you want to know about neck mass or neck lump in adult and you want to see it from RACGP. So just go to the Google and write neck lump in adult RACGP. And then you will get this guideline. So go through this approach to the neck masses in adults. And definitely you should read these guidelines to get a better idea that how we normally manage a neck lump in Australia. So you can go through this in your own time. I will show you the important ones. So investigation, the first line investigation for all adults at risk of malignancy consists of a CT of the neck with contrast and FNAC. Okay, so CT should be considered a first line investigation for all patients who you think that can have malignancy, not ultrasound. So the thing is, if it is an adult, your first investigation for a neck lump, and if you are suspicious of a cancer, is CT, not ultrasound. Once CT shows that there might be something going on there, then you send that patient for FNAC. Well, ultrasound can be done, but it is not recommended as a first-line investigation. Okay, so that's what I wanted to show you. But if it is a children or pediatric patient having a neck lump, then you would go for an ultrasound first. And then if ultrasound shows there is some suspicious thing going on, then you go for FNAC. So children and adult neck mass, there is a bit difference in how we manage. For adults, CT first, followed by FNAC. For children, ultrasound followed by FNAC. We are not talking about thyroid, okay? So this is not thyroid. We already know this is parotid gland swelling. So if it is neck lump, so thyroid, we don't think thyroid is a bit different than all other neck lump. Okay, except thyroid. So thyroid, we will discuss when we discuss about the thyroid gland abnormality. So for thyroid, yes, we do ultrasound sometimes, but there are some specific time when we will only do it. That's a different topic. But for a parotid gland swelling or salivary gland swelling or any other neck lump, except thyroid, let's say, CT should be your first investigation of choice. No, it's not a screening. So the thing is that we can do ultrasound, but most of the time ultrasound cannot give us a specific information. And even if ultrasound comes normal, you will send this patient for a CT scan. So that's the problem. So that's why, according to the RSCGP, if you think that this patient might have a cancer or if there is a risk of malignancy, in that situation, we would definitely go for a CT first, followed by FNAC. But in time to time in our practice, we do start with ultrasound. If we think that, well, the lump is not very hard, it's not irregular, it's very cystic or smooth, then yes, we send them for ultrasound. But in this particular case, when there is a parotid gland swelling, it is either a parotid adenoma or it is a parotid carcinoma. Okay? Or it could be a salivary gland stone. But for salivary gland stone, there is a different way of presentation. Okay? They will not come to you as lump, rather they will come to you with painful swallowing or excessive salivation. So it will be a different approach. It's not like that. Not every parotid cancer will cause facial nerve palsy. Okay? Not every parotid cancer will cause facial nerve palsy. Definitely, it is a good sign, but it can be a small cancer which is not big enough to cause facial nerve palsy. We never know until we do a FNAC. Moving on to the next one. So you have got a patient who had a fall from a bicycle 1 week ago and also resulted in helmet fracture. No confusion, no amnesia. Patient has headache which increases with coughing. What does it mean? Headache increasing with coughing. Can you think of anything that can cause this? Yes, raised ICP. So raised intracranial pressure can cause a headache which gets worse with coughing. So a patient who had a trauma or fall from a bicycle having sign of raised ICP means that patient is bleeding inside. The question is, what kind of bleeding? Is it a intracranial hemorrhage? Is it a epidural hemorrhage or subdural hemorrhage? This is the three things that can happen in this patient. First of all, if it is an intracranial hemorrhage, this patient will not last for a week. This patient would come to you before 1 week if it is an intracranial hemorrhage, right? So we can remove this option. Other option like concussion, subarachnoid hemorrhage does not present in this way. So this is also out. These are the two options. So is it epidural or subdural hematoma? That's the question. We will discuss this two, then we will come to this topic. First of all, epidural hematoma. Epidural hematoma, when you do a CT scan, it looks like this. So it looks like a biconvex appearance. And blood looks white on a CT scan, so that's why it is looking white. So biconvex shape hematoma, it is epidural hematoma. So what is epidural hematoma? When there is a blunt trauma to the skull, it can cause laceration of the artery, most commonly the middle meningeal artery. And most of the time, the fracture happens around the temporal bone. In contrast to the subdural hematoma, to cause arterial bleeding, a tremendous force is usually required. Now, this is the clue. If someone has got epidural hematoma, the force of trauma needs to be extremely high. Okay. Now, for this patient had a fall from the bicycle and there was a helmet fracture. Now, definitely helmet is not very easy to have a fracture. Okay, so when there is a tremendous force or injury, then only the helmet can get fractured. So that's the time you would think that most likely this patient has got a epidural hematoma. Okay, but epidural hematoma can have various kind of presentation. Epidural hematoma can have a triphagic presentation, like initially they will have a loss of consciousness, then there will be a lucid interval which can last for minutes to hour. So in the lucid interval time, patient will be completely normal. You will think that patient is better. That will be followed by headache, progressive obtundation, and hemiparesis. So initial loss of consciousness, then coming back to normal, and then becoming much worse, even going into coma. That's usually a triphagic presentation for epidural. Now the question is, it's not always that you will get this kind of symptom. You may or may not get lucid interval in an epidural hematoma patient. Not always is the case. How about subdural? Subdural hematoma happens because of rupture of the bridging veins. Now, these veins are easy to rupture because brain floats freely in CSF where the venous sinus are fixed. So what happens when there is an injury or a fall? Definitely brain will move, and when they move, it can rupture this bridging vein quite easily. So sometimes even a minor trauma can result in a subdural hematoma. Subdural hematoma, it can present in a lot of ways. They can have headache, altered mental status. Many times, this triphagic presentation like lucid interval is not usually found in subdural hematoma. Okay? When you do a CT scan for a subdural hematoma, you get this kind of crescentic shape. So the blood will look like a crescent. So that's how we can differentiate a subdural and epidural. So given that the helmet has been fractured, I would definitely go for epidural hematoma in this patient. Okay, clear? The same patient did not have a helmet fracture. The answer would be subdural hematoma. Okay, are you guys enjoying the session so far? You are getting along with me, because sometimes it can be hard, because this is the first time many of you are like getting the class. It might be overwhelming for a lot of you. For many, it can be very slow, I understand, but I can't go faster than this because many of you are beginner. And if I go faster, you these things will not go into your head. So as the time goes, these classes will become faster and faster. But initially, I try to get into detail as much as possible. Okay, great. Moving on to a genetic topic. A parent come to you because the son has got hereditary spherocytosis. They want to know what is the chance that his siblings will also get the same disease. So genetics is an important topic for AMC, but it's not like you have to be like you have to be an expert in genetics. You just need to have a basic idea. As long as you have got that, you will be fine in the exam. So I will go a little bit detail about this kind of genetic disease. First of all, hereditary spherocytosis is an autosomal dominant condition. So genetic inheritance can come as autosomal dominant, can come as autosomal recessive, it can come as X-linked recessive. Today we are going to discuss two things. One is autosomal dominant and another is autosomal recessive. So, autosomal dominant. I know genetics can be quite hard for a lot of you, but after today, it will be very simple and clear. Trust me. So, for the purpose of your understanding, let's say X and Y is the father and X and X is mother. Now, don't think that this is male and this is female because of X and Y. You can use AA and BB also. So one is dominant gene and another is non-dominant gene. Same, one is dominant gene, another is non-dominant gene. That's what matters. Okay? So you can also, let's just keep it AABB. That might become much easier for you. But let's go with that. So autosomal dominant is a condition where if only one defective gene comes from the parent, the baby will also get the disease. Okay? So it's a condition which runs through the family. If one parent has got the disease and that parent can give that defective gene to their children, and only one defective gene is enough for that patient to become fully active diseased patient. What does it mean actually? So let's say that father and mother, father had hereditary spherocytosis and this gene was defective gene. And they have got possibility of 4 different kind of genetic children. So what are those four different kinds? So one can be X and X. So X and X. Another can be another X and X. Then it could be Y prime X or XY prime. Or another can be XY prime as well. So you have got 2 children who hasn't got the defective gene and 2 children who has got the defective gene. And as I said, only one defective gene is enough for this child to become a diseased child. So what does it mean? It means that 50% of the children will be normal and 50% will be diseased. For autosomal dominant, it doesn't matter like if the children is boy or girl, they have equal chance of getting the disease. So boys or girls, anyone can get this disease. Okay? So 50% normal and 50% will be diseased in autosomal dominant. So if you come to here, hereditary spherocytosis is an autosomal dominant condition. And you can see that the son has got it. So the parent asking that what is the chance that the son's sibling, that means if this parent wants to take another child, what's the chance that that child can have the same condition? That's the main question. So what will be answer? 25% of his brothers, sisters, 50% of brothers, 0% of brother and sister, 50% of brother and sister. 50% of brother and sister. That's your answer. Always remember, in every pregnancy, there will be a 50% chance that the brother or sister can get this disease. In every pregnancy, just because son has got the disease doesn't mean that there is only 25% chance. Okay? It's the main idea is every time they will get pregnant, their children will have 50% of risk to get the disease and 50% of risk, 50% that they might be normal. Okay? So that's autosomal dominant. How about autosomal recessive? That's a bit interesting. For autosomal recessive to become fully active disease, they need 2 defective genes, not 1, like dominant. So let's say the same thing, XY, X and X. So father and mother, they have got children. And let's say one of the gene is defective. Like let's say, first of all, father is a carrier because there is a defective gene. Mother is a carrier because mother has got one defective gene. So both carrier, let's say father is a thalassemia carrier, mother is also a thalassemia carrier, and they have got pregnant. So there are four possibility of the children. So one can be X prime, X prime. Another can be X and X prime. Then can be X prime Y. And then XY. Right? So try to find out. So XY means they are normal. So this is normal child. There is one defective gene here, one defective gene here. So 50% will be carrier. And this one has got both defective gene. So this 25% is thalassemia major, which means fully active disease. So this question comes in exam a lot. If two carrier, like if father and mother is both of them are carrier of thalassemia minor, what is the risk that their baby can get thalassemia major? So there is 25% risk of thalassemia major, 50% risk of thalassemia minor, and 25% normal. Okay? So whatever scenario they give in the exam, if you know the formula, you can always come to the diagnosis. That's the main point of discussing this. Did you guys understand, like, what's the main point of this genetics? Is it clear for everyone? Okay, I didn't understand that. So I don't know what's your name, doctor. So you're using a Samsung phone. What's your name? Autosomal dominant. Yes, we can repeat the autosomal dominant. Let's show another one. So for autosomal dominant, only one defective gene is enough to become a fully diseased child. Let's say that this gene is defective gene and father and mother has got four possibility of children. So X and X, and then this X, this X. So first this X, this X. Okay, let's just erase this part. So you have got X and X. So this is one child. Then X and another X. Then you have got Y prime X and another Y prime X. So these two are normal because they haven't got any diseased or defective gene. So 50% normal, and these two has got one defective gene. That means they are diseased. So 50% diseased and 50% diseased and 50% normal. Okay, so it's about brother and sister. Remember that it doesn't, autosomal dominant can happen in both brother and sister. Okay, Dr. Sabanath. So it's not like that it will happen only to the boys, not to the girls. Any child can get it. And it's like in each pregnancy. So first pregnancy, 50% chance that the either the boys or girls will get the disease. Second pregnancy, third pregnancy, every time this father and mother will have a child, they will have equal chance, like 50% risk that diseased or their baby can be normal. And baby means either the boy or girl, anyone. And what is the problem with thalassemia inheritance? So for thalassemia, because it's a autosomal recessive condition, you need two defective genes. So father has got one defective gene, mother has got one defective gene. So both of them are carrier, and they have these four possible children. So 25% will be normal. When they have got one defective gene, they are carrier, so 50% is carrier, and one of them might get both defective genes. So 25% can get thalassemia major. Yes, so X-linked disorders, that's the time there will be difference of boys and girls, not for dominant or recessive. Like autosomal is different. Autosomal can involve either the boys or girls. But when we discuss about X-linked, that's the time, like X-linked recessive one, it only affects the boys. Like boys usually get the full disease and girls usually are carrier. So it's different for X and Y linked. Okay, moving on to the next topic. So you need to know some of the common autosomal dominant and some of the common autosomal recessive conditions, because they will just give you like this. So they might ask you that what is the inheritance for hemochromatosis? So you need to know hemochromatosis, what's the dominance? Is it autosomal dominant or autosomal recessive? So some of the common conditions, genetic inheritance, you should know. Okay. Next question. A nurse suffered needle stick injury at your ward. Now, this is a very confusing topic, trust me, and many of you will get confused. But I want you to understand that there is a lot to discuss about this topic, and it's not a part of our today's discussion. I will just go to the superficial one. She had previous hepatitis B vaccine 10 years ago with positive serology. That means that she was immune to hepatitis B. But she did not get any booster. Hepatitis B needs booster, because without booster, many of these people, they might lose their immunity. Okay, but she had a positive serology, and someone who had hepatitis B vaccine and they had a positive serology means that at one point they were immune to this hepatitis B, and they are called vaccine responder. Okay, that means they respond to the vaccine. Patient HIV negative, hepatitis HBsAg and hepatitis C virus PCR RNA positive. What will you do next? Okay, so a nurse suffered needle stick injury at your ward. When we discuss about something like a needle stick injury, we think about the victim. So victim in here is the nurse, and the source. Source is the patient who has, like, whose needle stick injury this victim has got. Basically, that's it. So victim and source. That's the two things we use. She had previous Hep B vaccine. So victim Hep B vaccine was given, but no booster. Patient is HIV negative. So source is HIV negative. That's very good. HBsAg positive. HBsAg positive means that the source can have a active hepatitis B. Can be a carrier, can be active. We don't know, right? And also hepatitis C virus PCR positive. That means the patient can also have hepatitis C virus. That means source can have both Hep B and Hep C. Okay. Up to this, are you guys with me? Like, are you understanding this part? Like, what is victim and what is source? And it means that the victim has a risk of getting both Hep B and Hep C. Okay? So what will you do in such situation? Are you going to do anything, or are you going to just review the patient? That's the main question to understand. Okay? So first find out what is the status of the victim and if the source has got any positive infection. So this source has got positive hepatitis B and hepatitis C. Okay? Now, let's come to the discussion. So this is a Queensland.gov.au. So this is a very good guideline for occupational needle stick injury. And I want you guys to go through that in your own time, at least few times. Let me open this guideline, just 1 second. So if you go to this table 5 in this 28-page PDF, then you will find out this table, which is very important for this question. So hepatitis B virus exposure follow-up. In here, you can see the source status, and in here, exposed or victim's status. The first thing is that if the victim did not have any history of hepatitis B vaccine immunity, what will you do? The other one is that patient was immune to hepatitis B at some point. What would you do at that time? So these are the two things. If this victim is immune or not immune, that also we need to know for further management. When we think that we need to give a hepatitis B post-exposure prophylaxis, which means that from the discussion we understand that the victim, that means the nurse, is at risk of getting hepatitis B and C. For hepatitis C, you don't have any vaccine or immunoglobulin that you can give that the victim will not get the infection, because there is no available Hep C vaccine or immunoglobulin. But for hepatitis B, you have immunoglobulin. And if you can give the immunoglobulin straight away, this patient might not get the hepatitis B. So that's the point of every discussion that we are having right now. So first of all, you can see that patient was previously vaccinated. That means our victim was previously vaccinated. Non-vaccine responder. Our patient is a vaccine responder because at some point she was immune to this. But we don't know what's her immunity level at the moment, right? So that's the first thing we need to know. Currently, if she has immunity to hepatitis B or not. Because if she has got the immunity, then you are not worried at all. You don't need to do anything because she is already immune. Non-vaccine responder, even if the current hepatitis B antibody is negative, still most of the time we don't need to do anything. Even at that time, you might not need to give any treatment. But it's a good idea to know the immunity for this patient, because in that case, you will be able to reassure the patient that your body shows or your blood shows that you have immunity to hepatitis B, so you don't have any risk. What about patient was vaccinated? That means the victim was vaccinated, but she was vaccine non-responder. That means in her blood, she had never got immunity to hepatitis B. For someone like that, you'll need to give hepatitis B immunoglobulin. When? If the source has HBsAg positive. So our source has got HBsAg positive, right? And if the victim was non-responder, then you would give a hepatitis B immunoglobulin to her. Okay, so that's the main understanding. There is a lot to discuss in here. I'm not going into that, but I want you to understand the step-by-step approach for this kind of post-exposure prophylaxis. So if you get a patient, a victim who can have a risk of getting Hep B, Hep C, or HIV, you will need to find out that if you need to give any post-exposure prophylaxis, like do you need to give immunoglobulin or do you need to give antiretroviral to this patient? Okay, so for this patient or for this nurse, she is a vaccine responder, but we don't know her current immunity status. So first thing I would do is to check the hepatitis B antibody level. We don't need to give antiretroviral because we only give antiretroviral for HIV. So it's not needed. Repeating the RNA after 3 weeks is not needed. Okay. What we do in hepatitis C virus like victim is that we gradually follow their liver function test. We repeat their hepatitis C virus antibody and RNA level, sometimes at 3 weeks, 6 weeks, and sometimes even 6 months. Okay. But for now, for this particular patient, your first priority is to know the antibody level for hepatitis B, at least to reassure the patient. Okay. Clear, everyone? Is it making sense? According to the Queensland guideline, because she is a vaccine responder, even if she doesn't have immunity, like hepatitis B antibody is less than 10, still we don't need to do anything. And this is not from a book, Dr. Jeba. It's from Queensland post-exposure prophylaxis. So if you write in the Google, occupational needle-stick injury management, Queensland, this will come up. But yes, we would give, Dr. Prakash, that's a very good thing. If this patient is non-immune to hepatitis B, then definitely you will advise the patient to get a booster. That's obvious. I'm not going to discuss about Hep C and HIV today. We will discuss it in the course. Okay? It's a lot of discussion. Let's move on to the discussion about few other topics. Before we do that, it's been a while that we have been discussing this. Let's take a 5-minute break, and after that, we will again come back and we'll do some discussion. Okay. Five-minute break, guys. All right, everyone, let's restart again. Okay, so one of the question I can see you guys are having confusion. Yeah, so if there is like most of the time what we normally do is that even if the patient has got is a primary responder, still we check their hepatitis B antibody level just because that if that patient is not immune or currently the hepatitis like the antibody level is less than 10, you will at least be able to tell that patient to get vaccinated because she is a nurse and she is not actively immunized at the moment. Then yes, definitely we would say like she needs to get vaccinated. For anyone who is working as a nurse or occupational or like healthcare professional, their hepatitis B antibody level has to be more than 10. Okay, so definitely we will ask her to get that tested, and if it is less than 10, she will need the vaccine. Because a lot of nurse, lot of doctors, they are vaccine responder. Initially, they had a HBS antibody more than 10, but now after 10 years, the immunity is no longer there. They have always a risk of getting the infection. Okay, so for them, we will need to ask them to get vaccinated at least. That's a must. Next question, a lady comes to you with weakness of lower limbs. She drags her foot while walking. Dorsiflexion and plantar flexion is weak. Reflex exaggerated. Equivocal plantar response. What is the diagnosis? Very tricky question. So you have got a, let's say, 50-year-old female who is having weakness of both lower limbs. She is dragging her foot while walking. Dorsiflexion, plantar flexion is weak. So definitely there is some weakness on the lower limbs, but reflex exaggerated with equivocal plantar response. Do you think it is a cervical spine MS, like a multiple sclerosis, motor neuron disease, spinal canal stenosis, lesion in the cerebral cortex? Lesion in the cerebral cortex is not a diagnosis. If the question was asking that what is the cause, then we can think of this D option. When they ask about will you think, let's say there is a condition which is motor neuron disease. We will discuss this in detail in our neurology class, but get an idea about it. Motor neuron disease is a condition where all the motor neurons in the body can get affected. Okay, so every upper motor neuron, lower motor neuron, any motor neuron can get affected in here. But there will be no problem with sensation. In motor neuron disease, there are few subtype of it. There is one subtype where you only get like lower motor neuron type of palsy. There is one subtype which is the commonest one where you can get both upper and lower motor neuron type of symptom. What is upper motor neuron and lower motor neuron type of symptom? Upper motor neuron type of symptoms comes with spasticity, whereas lower motor neuron comes with flexidity. Both will cause weakness, but one will cause a spastic paralysis, another will cause flaccid paralysis. Then upper motor, it will cause hypertonia, where lower motor will cause hypotonia. Upper motor will have hyperreflexia, but lower motor will have hyporeflexia. Upper motor plantar response will be extensor, whereas lower motor plantar response can be flexor or equivocal. When you get in a single patient, like in a patient, when you get both upper motor and lower motor neuron type of symptom, that's most of the time we think of we think of motor neuron disease. Because this is the only neurological condition where you can get both upper and lower motor neuron type of symptom. For this patient, you can see that this patient have weakness in her lower limbs, but her reflex is exaggerated. So that's upper motor neuron type of symptom, but equivocal plantar response. So that's lower motor neuron type of feature. So when you have got both combination, that is motor neuron disease. So this is your answer for this question. Why not multiple sclerosis? Multiple sclerosis solely comes as upper motor neuron type of palsy. And if it is cervical spine, the main symptoms should be on the upper limb, not just lower limbs. That's how we know that it is not MS. For multiple sclerosis, not just motor neuron will be affected, sensation will be impaired as well. So a lot of things are there. Spinal canal stenosis also gives upper motor neuron type of palsy. And for spinal canal stenosis, if it is a lumbar spinal canal stenosis, patient will get pain in their back, and the pain will shoot into the lower limbs. So there will be some pain, but this patient does not complain of any pain. So that is also unlikely. Okay? Clear everyone why it is motor neuron disease? And this is where we have discussed what is the difference between upper motor and lower motor neuron type of palsy. The same question, but they're asking you, a 58-year-old man dragging the left foot, reflex on the left lower limb are increased, and there is weakness on the muscles of the lower limb, equivocal plantar reflex, upper limb face is normal. What is the lesion site? So if we are thinking of motor neuron disease, where is the lesion site for motor neuron disease? Motor neuron disease that affects the lower limb, it's most of the time it is the cerebral cortex. That's where it is the problem. All right. If it was brainstem usually gives us more features, like they get diplopia, nystagmus, vertigo. Those are main symptoms for brainstem lesions. Cervical spinal cord, if it was cervical spinal cord, the symptoms will not be on the lower limb, it should be on the upper limb as well. Common peroneal nerve is a peripheral nerve. It does not affect reflex, so it's unlikely. L5S1 nerve root. Again, if there is a nerve root problem, they come to you with pain, not with just reflex or dragging the foot. Okay. So the symptoms goes with motor neuron disease, and the lesion site can be any motor neuron anywhere in the body. Could be in the brain, could be in the cerebral cortex or spinal cord. Okay, but from here, the option cerebral cortex is only here, so we'll choose this one. Sometimes question come in the exam from motor neuron disease that what is your next most appropriate investigation for this patient? Because MND sometimes can mimic some neurological condition, the initial investigation for motor neuron disease is MRI to rule out any other neurological condition which can mimic MND. So initial investigation should be MRI, and if they ask what is the most appropriate or confirmatory investigation, that will be electromyogram, EMG. All right. So that's motor neuron disease. Now, this is a funny picture, but it explains a lot of your thinking, a lot of your confusion, that if the cerebral cortex is affected in this patient, why only lower limb is affected? Why not the face? Why not the upper limb? There is a reason behind it. This is called homunculus. In homunculus, you can see that the cerebral cortex, this part of the cerebral cortex mainly helps with the face. This part helps with the upper limb. This part helps with the trunk. This part helps with the lower limb. So if there is a problem in this part of the cerebral cortex, then only lower limb will be affected, not the others. Okay? So that's why this patient, even though it is a motor neuron disease, not the whole body is getting affected, just the lower limb is getting affected. Okay? Good. Moving on to the next question. You have got a 60-year-old patient with joint pain and swelling. Let's say knee joint is painful and swollen. known diabetic for 20 years, hypertensive for 15 years, had a stage 3 CKD with 42% GFR. The knee joint is warm and tender, mild fever, otherwise vital is stable. Joint aspiration shows WBC definitely very high and birefringent crystal positive. Culture shows no organism. What is the next most appropriate action? So this is a very typical exam type question, and it mainly try to examine you that how much knowledge you have in this kind of scenarios. So what is the diagnosis? If a 60-year-old patient coming to you with a knee joint pain, like an acute knee joint pain, you would think of 3 possible diagnoses, like a acute one. So acute knee joint pain can be done by septic arthritis, can be done by gout, can be done by pseudogout. How to differentiate this? You do the joint aspiration. With the joint aspiration, if you get crystal positive, then it is either gout or pseudogout. And you also send it for culture. If culture shows no organism, it is not septic arthritis. Okay? So you know this patient has got either a gout or pseudogout. Then you look at if is it a positive birefringent crystal or negative birefringent crystal. If it is positive birefringent crystal, it is pseudogout. If it is a negative birefringent crystal, that's gout. Now, I'm not going to discuss pseudogout, gout in detail. We discussed this in our connective tissue disorder and arthritis or rheumatology class. But pseudogout, definitely it is a crystal arthritis. So there is calcium pyrophosphate deposition in the joint causing this pseudogout. Most of the time, these patients are known osteoarthritic or has underlying joint problem initially. And on the top of that, they can get this crystal deposition causing a sudden onset of like inflamed joint, causing pain, swelling, and restricted movement. For managing a pseudogout, our choices are like this. So you can start the patient with aspiration and installation of steroid inside the joint. You can use indomethacin, which is NSAID, colchicine, or paracetamol. Okay? So any of this, the best for this kind of patient is paracetamol, if that is in the option. And even for this case, in E option, if there is a paracetamol, I would choose that. But let's say paracetamol is not in the option. Then our option is NSAID, colchicine, steroid. The steroid is not given in JAM, but in lot of other guidelines, we can give steroid in an inflamed joint. Now, the question is which one to pick. There is no colchicine in the option. If there was a colchicine in the option, I would definitely choose that as well. Because we can give colchicine in a CKD patient. So colchicine is also not in the option. So if there was paracetamol, that would be my first choice. Second choice would be colchicine in this patient. Given that this patient has got a stage 3 CKD, I would not choose NSAID in this patient. That's not going to be the best option. Okay? Allopurinol is not indicated for pseudogout. It's not septic arthritis, so no need of flucloxacillin. So when you don't get any specific answer that you know, you try to exclude. And by exclusion, we have this option, and that is the best option out of these 4. And that is something which you would do in the real exam. When you can't see the answer that you're looking for, then you try to exclude. And by exclusion, you will come to your choice. Now, steroid for a very short period of time will not cause any problem with a known diabetic for 20 years. Okay? But definitely an NSAID is contraindicated in a stage 3 CKD patient. But Steroid is not contraindicated for a diabetic patient. Yes, it can increase it, but it will be just for a few days, 3 to 5 days. Okay, so for this kind of patient, steroid will be our best option out of these 4. But look for options such as colchicine or paracetamol. Okay, next one. You have got a 5-year-old kid who has aspirated 2 tiny magnets. Came to the emergency department after 4 hours. You have done an immediate X-ray. Magnet is still in the small intestine. And then after 6 hours, you did another X-ray. Magnet is still in the same position. So this is a 5-year-old, 2 tiny magnet aspirated, and it's not moving. What will you do next? Immediate laxatives, immediate surgery, do nothing, serial X-ray, immediate endoscopic removal. So let's discuss this and then we will come to you. Solving foreign objects is not uncommon in children. But we need to know what are the high-risk foreign bodies. Any button batteries are always high risk. Large object such as more than 6 centimeter long and more than 2.5 centimeter wide. Magnet plus metal. More than 1 magnet. So our patient had 2 magnets. So it's a high risk. Lead-based object or abnormal GI tract. So you have witnessed that this child might have aspirated a magnet. Or you have done an X-ray, and in the X-ray, the foreign body looks like a magnet. Then you look at 2 things. Is this child symptomatic or asymptomatic? If it is asymptomatic, then is it just a 1 piece of magnet or multiple pieces? If it's 1 piece, then you can do serial X-ray daily, and you can do a serial X-ray every day and see that if the magnet is moving towards the anus. If there is no progression of that magnet for 24 hours, then there is a possibility that there might be more than 1 magnet there. Then consider doing a lateral X-ray. And also for that patient, you will need to go for removal by endoscopy or surgery. So if there is no movement for 24 hours, even if it's a single magnet, you're going to go for a lateral X-ray first, followed by removal. But if with the X-ray, you can see that after 24 hours, it has moved a little bit, then another 24 hours, there is no longer foreign body. That means it's been gone. So you're fine with that. Multiple piece of magnet, serial X-ray every 4 to 6 hours, no progression on X-ray for 4 to 6 hours. So if the child is symptomatic, it doesn't matter is it 1 piece, multiple piece, you will remove it. But if it's an asymptomatic child, but for 4 to 6 hours there hasn't been any progression, also you'll need to remove it. See another one, multiple magnet digestion. You have done a chest and abdomen X-ray and you have identified multiple magnet. Look at this. If the magnet is within esophagus and stomach, then you can remove it endoscopically. If it is beyond the stomach, like if it is in the intestine, remove any magnet and metallic object nearby, follow with serial X-ray. Basically, we say that if it is beyond the stomach, you keep on doing serial X-ray. If it is asymptomatic, and if it is moving, then you can allow it to pass naturally. If it is lost in the truck, that means it's not moving for 4 to 6 hours, there is no movement, then surgery. It is symptomatic, also surgery. Okay, so that means if you want to remove the magnet, you can remove it by endoscopy if it is still within the stomach. Beyond the stomach, you will need to go for surgery if the magnet is not moving or patient is symptomatic. In those situations, surgery is the only option. You can't remove it by endoscopy. So what do you think about our patient? Multiple magnet. You have done an X-ray. Initial X-ray showed it was in this small intestine. And after 6 hours, magnet is still in the same position. So after 4 hours, you have done a X-ray. It was in this small intestine. And then 6 hours after that, there is no movement. So it means that the magnet is not moving. So what will you do? This patient will need a surgery. Okay? You can't do a endoscopic removal because it's in the small intestine. If it was in the stomach, then you could do a endoscopic removal. Okay? So this is the main thing. I want you guys to understand that having a good theory knowledge can help you to get into the right question. From anywhere the question coming, if you know the topic well, then you will come to the diagnosis, you will come to the right answer. So this is the last flow chart. These are all Australian guidelines. Yes, so if it's in the stomach, then endoscopic removal. Beyond the stomach, only way to remove it is by surgery. Okay. Last question for tonight. CVD risk assessment chart. So cardiovascular risk assessment chart is super important for exam. Nowadays, it has been changed a little bit, but the idea is still the same. So sometimes they will give you a question where they will provide you with a cardiovascular risk chart like this. And they will ask you what is the risk of like cardiovascular event in this patient in the next 5 years. So you have got a 60-year-old smoker woman. Blood pressure is like this. Cholesterol HDL ratio is 6.6 by 1. What is this patient's 5-yearly CVD risk? If you look at this chart, you can see on the top people without diabetes, and you can see women and men. So our patient is women, and in here you can see the age. So find out what's the age of this patient, 64. So 64 means this group. So you are only looking at this box, none of the other. And then there is a non-smoker and a smoker. Our patient is a smoker. That means this is the box that we are going to look at, right? So far we have found out that which box is important for this patient. Then you look at that in the y-axis, you have got systolic blood pressure, and in the x-axis, total cholesterol and HDL ratio. First, systolic blood pressure. When we look at the systolic blood pressure, you can see 120, 140, 160, 179. Yes, the chart will be given in the question. So This is the most important thing to understand, because this is kind of a graph, and you all know how to do a graph, right? So just because it is written 120 in this box, it doesn't mean that the highest limit for this box is 120. So highest limit for this lower box is 130. So add 10. Okay. So 130 is the highest limit. For this second box, 150 is the highest limit. Then there is 170. So you just add 10, and that will be the highest limit. Okay, like if a patient has got systolic blood pressure of 125, then this is the box where you will put the patient, because up to 130 is the highest limit. Okay. The other thing to understand, that even though the highest limit is 130 or 150 in this box, if 130 is given, that means the marginal one is given in the exam, then we will go to the next box. Like if this patient's systolic blood pressure is 130, because that is marginal, we will always jump to the upper box. I will show you some example, don't get worried. So highest limit for this box is 130, for this box 150, for this box 170. Is it clear for everyone? If not clear, just ask me now, because we will not be able to repeat this again, because this will be repeating the whole thing again. So I will ask you in the middle so that I understand we don't need to repeat this. Good. Not clear? So Dr. Lindell, you can see that this is a graph, and they will give you systolic blood pressure. Like in this question, they have given you systolic blood pressure 135. So where you are going to put 135? You know that up to 130 is this box. So 135 means you'll choose the second box for this patient. Okay. How about cholesterol and HDL ratio? You can see 4, 5, 6, 7, 8. So this is the ratio. Highest limit for this box is not 4, it's 4.5. So highest limit is 4.5. For this box 5.5. For this one 6.5, 7.5, 8.5. Okay. Now in our question, cholesterol HDL ratio is 6.6. So where we are going to put 6.6? So we know that up to 6.5 is this box. So 6.6 will be in this box, right? Is it clear for everyone? Now come to the diagnosis. So we know that this patient has got 135 systolic blood pressure. So 135 means this box is our box. And we know that HDL cholesterol ratio will fall in this box. So we'll go up and see where it meets. So it meets here on the yellow box. Okay. Now, what does yellow box means? That's the question. So that will be given in the exam, that what does yellow box, green box means. So let's go to SA Heart. So southaustraliaheart.com.au. This is the guideline. So this is the cardiovascular risk chart, and YOLO means risk is 16 to 19%. Blue means risk is 10 to 15%, and green means 5 to 9%. If it was red, more than 30% risk. So that will be the question. What is the risk of this patient to have a cardiovascular event in the next 5 years? And based on your graph, you will find it out. Okay? Not very hard, right? Let's say if I give you let's say I'm giving you one of the other one. So you have got a patient who is a 50-year-old male, smoker, systolic blood pressure is 145, or blood pressure is 145 by 85, and cholesterol HDL ratio is, let's say, 5.5 by 1. What do you think you will do for this patient? So it's men. So this side, smoker, this side, 50-year-old means this one. So I'm looking into this box particularly. Now 145, where 145 will be? 145 will be in this box, right? So because up to 150 is this box. And then we have got 5.5. So we know that up to this box is 5.5, but this is marginal, so we are going to choose the next box. So we'll go up. So that means the blue box, right? So what is the blue? Blue means, as we can see, so blue means 10 to 15% risk. Okay? So that's how we know. This is how the question comes. These questions carry high mark in the exam. And if you know these kind of questions, you will get more mark in the exam and more chance of passing the exam. Yes, in real practice, we use this kind of chart. Okay, now that brings us to the finishing of this tips and tricks class. I know that it is quite tricky for many of you because many of you don't have any idea about how AMC MCQ works. But it gives you a perspective that what kind of question, how the questions come in exam. And now you had a theory class, you had a question solve class. Now you will get a clear picture that how to start your preparation. And now you should also understand that your theory classes are very important. If you have a good knowledge on theory, you can solve questions very easily. Yeah, the coding chart will be given in the exam. So you don't need to memorize anything. So this is the free 2-week session. The schedule of this free 2-week session has been given to the First Aid AMC MCQ group. And you'll see that your next class is going to be on. So there is one, like for those of you who are already part of the course, we have given you a schedule on your Facebook. Okay, so just have a look about the schedules and the classes will be taken in that way. Okay. And for everyone else who hasn't joined the course yet, for you, the schedule is given on our official Facebook group. So keep an eye on that and just join the classes as we are asking. For 24th February trial class, the class recording is given. So Dr. Naomi, if you are already a part of our course, then you will get it in the portal. If you are not a part of the course, then you can get it on our official Facebook group. Just search by writing recording and you'll be able to find that class. And there are lots of groups, like we have Telegram group, WhatsApp group, but we don't add anyone in this initial 2 week sessions. After 2 week session is over, you will be added to those groups. Yes, this class, any class that we take will be added to First Aid AMC portal. Now, do you guys have any question about the course? I'm going to give you a basic idea about how our course is going to be organized, and then I will come back to your questions. Okay, so this is a new course which we have just started today. And remember, these free sessions, this will not be repeated. This is a part of the course. This is a course class, but we allow anyone to join these classes for them to get an idea about our class, so that they don't feel that we are just taking one class and then after that you don't like the class. So as I say, that if anyone can take 2 weeks class and you like that classes, that means you are good with that. Okay, so it's a safe option. That's why we give it to you. And also, it's very good to know the mentor before you join any course. And I'm sure this is helping a lot as well. So free 2 weeks class has started from 9th of March, which is today. The schedules are given in your Facebook group. I will show you the Facebook group. The Zoom ID will be more or less same like today's class. The trial class recording, you can get it in the YouTube also. So in YouTube, if you search First Aid AMC, you will see a lot of our recorded classes there as well. Course summary. So we discuss everything for the exam. You get the full theory. You get 5 yearly sample question discussion starting from 2018 up to 2024. But we mainly focus on the new ones, which is 2024. But in our portal, you will get all these 5 years questions solved with recorded classes there, which is a huge amount of collection. You get the software-based mock exam. So we have different kind of mock exams, subjective, monthly, full mock exams. So there is a huge amount of mock exams, and every month we add new mocks. You get a Q bank after 2 weeks is done. Access to the course note until you pass the exam. So you'll get the access to the notes and mock exams until you pass. Recording of the classes with the extension up to 10 months. And also you can add CPD hours if you're a member of RACGP or ACRAM. Course fee is $499. There is no installation available for this course. It's a 5 months course. Classes are taken at the moment 3 to 4 days a week. Mostly the class schedules are Friday, Saturday, and Tuesday, but sometimes you might get 4 classes in a week as well. Our classes are divided into 2 theory classes every week and 1 or 2 question solved classes every week. Class time will be same, 8:30 to 10:30 p.m. Sydney time. All classes are live classes on Zoom, but the recordings will be available in your portal, ideally after 24 to 48 hours of each class. The theory, mainly we focus from JM and Kaplan Step to CK, and also some other Australian guideline. You get theory-based question discussion, like from 12th of March, so we will start the cardiac classes. So after cardiology, you will get our cardiology question solve class. So that's theory-based question discussion. You get also theory-based practice test in the software. So you can, once you finish cardiology, you can definitely go for a cardiology mock exam and find out how much you are doing. Like, are you passing the cardiology or not? As we say that there is 5-year recent sample questions are already there in the portal. And again, every month we are adding new questions, and you get the question solved classes as well. In here, we discussed about how many mock exam we have in the portal. Extra classes, we take extra classes with ECG, CT scan, X-ray, CTG, STAT, ethics, fundoscopy, and ABG, and any other extra classes that come across. Okay, so few people might not have 4-5 months before your exam. But that's not a worry, because as I said initially, that when you join the portal, you will get full access to all of our previous batch class recordings. So if you're in a hurry, you can always go through that. Once this 2-week session is over, we are going to have a orientation session for the course student. And in that class, I will show you how actually the portal works and from where to read and everything. Okay. So that's pretty much it. This is our website. So if you want to go to the website, first write firstaidamc.com and it should pop up. Okay? So that's pretty much everything about the course. And as I said, that our course has everything that you need to pass the exam. And this is not a new course. We have been running this course for more than 7 or 8 years. And every year, we have got one of the highest number of passing students from AMC, both MCQ and clinical. Last year in October, November, we had more than 50 students. Like even in November, there were more than 50 students who passed the exam in a single month. So it's not a new course. It's not something which we are experimenting. We are professional of what we are doing, and you can rely on us in every possible way. And I'm sure you'll love it, as everyone else did. Okay, let's go to your questions. You can also ask questions by unmuting yourself if you have any queries. Yes, so the psychiatry classes are not done. Psychiatry classes will not be done in this 2-week session. It will be done as part of the course. You don't need to read topics before our classes. You can listen to the class first, get an idea what are the important topics, and then go to the topics. Q banks will be given. Next class will be on 11th March. So for course students, yes, there is a 11th March class, but for non-course student, the next class will be 12th March. Do we get today's recording on our portal? Yes, you will get it, but it might take 24 to 48 hours. And yes, you get recordings and mock in the portal. BP 150, then we go to the next box. Okay, let's see what do you have got in here. So if BP 150, yes, so if BP is 150, you will jump to the next box. That's right. I think we explained about weekly how many days and hours. Our classes are 2 hours. Do we get weekly mock after finishing each system? There is already a lot of mock available. Okay, so you can always go through that mock exams, and we add monthly mock in our portal. What if we join course after 2 months? I don't think it's a good idea, because after 2 months there will be a lot of things which will be already covered, and it's a bit hard to join a course in the middle. It's always best to join initially. And we have already updated in the course group for Dr. Atia, like those who already joined the course, they are added to the course group for Facebook. And we have already written what books you need, so you can start buying them. And we have already shared some PDF for soft copies. We are not on Instagram, unfortunately. Does your software support Android? Yes, it does. For cardiology, I would say you don't need to read anything just yet. Wait for the class. And the notes are only given for course student, Dr. Khin. If you're a part of the course student, it is already given in your portal. For theory classes, I am the only teacher, Dr. Hema. For course enrollment, you will need to send me like if you are a part of the First Aid AMC MCQ group, then you can definitely find my ID, Arshan Ahmed, and then you can inbox me. Once you send a message, then we will send you the invoices and further informations, or you can definitely send us an email. All the posts in our First Aid AMC MCQ Facebook group, we always give you the information of how to contact us. So this is First Aid AMC MCQ Facebook group. This is where we are mostly active in any kind of social media. So this is the most updated, and everything we update in here. So you can see every update in here, like when are the classes are coming up. The recordings are given in here for the 2-week sessions. And in here, if you go down, or if you go to the featured section of this group, then you will see all of the class schedules. You will see the Zoom ID, the details that we have discussed, and then you can also see how to contact us. So this is our email ID, firstaidamc4536@outlook.com. And if you want to contact us for any enrollment or any queries, either you can send me an inbox or you can just send an email. That will do. UWorld USMLE is helpful for only psychiatry preparation. We don't discuss handbook in the class, but that is something which you will need to read by yourself. Yes, Dr. Vignesh, you can decide after joining the cardiac classes. The initial 2 weeks classes are free for everyone. Okay, so if you haven't joined the course yet, you can still wait for the 2 weeks free session to be finished, and then if you feel right, then you can join. No problem. Yes, we discussed recalls or question solve. So you'll see in here the class schedule. You can see that there is recent question solve classes. This will be one of the question solve class. This will be taken by Dr. Rabia. Then there is 23rd March, there will be another question solve class. But once we start the full course, there are 7 to 8 question solve classes in a month. So there's a huge amount of question solve that we do. Feedback are given by the portal because it's already portal based or software based. You can see everything in the portal, what you have done mistake, what are the correct answer, and everything. Courses are every 5 months. So this course has started in March. So after 5 months, probably in August, we'll start another course, Dr. Prakash. And to subscribe the portal, first of all, you will need to make the full payment, Dr. Lindell. So contact with us first, and then we will go through with that if you haven't joined the course yet. And if you are a part of the course, Dr. Love Curry, in that case, you have to make an account in the portal. It might take few days because everyone is asking for the access once they made the payment. So it takes some time now. Even you might need to wait for a week to get the portal access. That's why we say that if you think that this is the right course for you, then don't wait. Just join and make the payment because it can take even a week or so to get the full access. Because there's a huge amount of students who join our course because we run the course only twice in a year. And so this is definitely a course which is highly recommended and a huge amount of students join. And sometimes what happens is that the students can help each other because there is a lot of students preparing for the exam. It's a kind of like a study hub it becomes. And with a lot of students, they form lots of groups. They do a lot of study partners. So it becomes a very good, effective course once you join. Okay. And if you have already joined the course and you have access to the portal, then the notes you will find out is in the theory section. So the theory classes are in the theory sections. all the recall or question solve classes are in the sample question part. But I will discuss all of those in the orientation class after these 2 weeks. You don't need to finish the whole jam, only the topics that we discuss. We will talk about the EPIC verification once the course starts, Dr. Atia, not today. It's a big thing to discuss. The handbook you can start reading now. So even the students who joined our course 1 month ago, we advised all of them to start reading the handbook. So handbook is a total different thing. It gives you an idea about AMC MCQ. So you have to read it 2 or 3 times. So just start reading at the moment. Yes, study groups are very important part of AMC preparation. So all of you should have some study partner. So at least 4 to 5 study partners should be there. Yes, you will get the PDF, like every classes that we take, the video recordings, class notes will be uploaded to the portal. So it's everything portal based. No specific month for booking the exam. If you are well prepared, you can pass at any month. So those myths are not needed. Now, EPIC and AMC portal, it's not must to do just now, but I would say that start the process, get the AMC portal and EPIC, start the process, okay? Because it takes maybe 2 to 3 months to do all of those things. So once it is done, only after that you can book the exam. So if you are part of this course, our course most likely will finish at August. So yeah, in August, first week of August. So you'll keep August and September to revise everything, then go for the exam in October or November. That should be for all of you, this should be your main thought. And if you want to give earlier than that, that's not a problem. Because as I say, everything is already given in the portal. You don't need to purchase any QBank or anything. This course is enough. All right, guys. So I'm not going anywhere. You will still get another 2 weeks free session. So if there is any questions, you can always ask me in those classes. Okay. So no problem. Start studying. It is like, I know there's a lot of questions in your head at the moment, and I will be more than happy to answer each and every queries as we do in the course as well. So you're always welcome to ask any kind of questions, even if it is the stupidest question. It is fine because you are new and you can ask. Without asking, if you sit and just don't do anything, that's a lot worse. So ask questions if you are not sure, but definitely start your preparation. It is the time now. There is no more time to waste. Okay. And Dr. Prakash, definitely we will reply you on the Facebook. As I said, sometimes because this is the weekend time, Saturday, Sunday, our team members are not quite active on these weekends. As you can understand, for anyone in Australia, we can't ask to be super active in the weekend time. Okay, but definitely someone will reply you. And Dr. Wahid, how you should start from the beginning? So start reading the handbook and also start reading the classes that we have already taken. So start the psychiatry class because we have already done one class, finish that one. And then from 12th of March, we will start the cardiology class. Then definitely you should start the cardiology as well. So the main idea should be finish the classes that we are doing as soon as possible. And in the meantime, you can go to the portal and listen to some of the recorded classes, especially the sample question discussion classes from the previous batch to get some idea about some of the important topics and questions that are coming in the exam. Dr. D, Getting into Australia as part of AMC exam will be very hard. I would not recommend that. Getting the visa is very hard, for especially for part 1, because you can definitely go to your nearest country. So visa can be rejected on that part. All right, everyone. So I'll finish it here tonight and join these 2-week sessions. Find out if it is important for you or if you're enjoying the sessions, and that's more than enough for you. Okay. As I said, that the course has everything that you need. There is nothing else you need to do by yourself except reading the things that we are showing you, except doing the hard work and also giving time for preparation. If you can do that, you can pass this exam within this year. And that should be your goal for everyone. You can't go beyond this year to appear the exam. Okay? And Dr. Atia, if you miss the psychiatry class, there is recording given in the Facebook group. And when you join, if you are a part of the course, that will be given in the portal as well. Thanks all. Have a good night. Take care.